Welcome and good morning, and I'm thrilled and honored to be here with both of our speakers this morning. So I will start with Dr. Joohi Jimenez-Shahed, who is the Associate Professor of Neurology and Medical Director of the Movement Disorders Neuromodulation and Brain Circuit Therapeutics Program at Mount Sinai, and currently serves as the co-chair of the Parkinson Study Group, where she previously chaired the Functional Neurosurgical Working Group. She is also past chair of the Science Advisory Board of the Davis Phinney Foundation. Thank you so much for being with us this morning. And Dr. Brian Kopell, Professor of Neurosurgery, Neurology, Psychiatry, and Neuroscience, and Director of the Center for Neuromodulation and co-director of the Bonnie and Tom Strauss Center for Movement Disorders at Mount Sinai. Thank you for being with us, Dr. Kopell. We can tell you both have a lot on your plates, so we really appreciate you taking the time. This is really important information and cutting edge, so let's just dive right in. So first, Dr. Shahed, can you share a brief overview of the pathology of Parkinson's disease and what are the typical symptoms?
So I might start with just the typical symptoms first, but I also just want to thank you for inviting us here for this presentation today. We're both very passionate about patient education, so we're happy to share our experiences and our insights and also to answer your questions. So Parkinson's, I think people recognize it as a condition where there are a number of different motor symptoms, right? So the main things are things like tremor, stiffness of the muscles, difficulty with coordination or slowness of the movements, and then also some gait and balance changes. So these are the main sort of physical symptoms that we associate with Parkinson's disease, but we do know that underneath all of that, there are a number of what we call non-motor symptoms. And so these can affect a wide variety of other body functions, including things like mood and memory, sleep, bowel functions, bladder functions, et cetera. So there's actually quite a few different types of features of Parkinson's disease that we will manage aside from just those physical symptoms. And then from just kind of a why does it happen sort of standpoint, we have a hard time, I think still, despite all the advances in science that have been made, identifying specific causes for individual patients. We think that, or we know that there's probably about 10 or 15% of patients who have this because of a purely genetic condition, while probably the remainder experience some sort of genetic predisposition combined with some sort of an environmental exposure that triggers the process that starts causing the symptoms of Parkinson's disease. So hopefully that kind of summarizes things, but.
Absolutely. Dr. Kopell, do you have anything to add?
No, I think that's a good point. You know, when we were first trained, it was called idiopathic Parkinson's disease. And then we begin to see these genetic predispositions. I think, you know, on some level, the take-home message about these genetic predispositions is not that, oh, gee, if I have this gene, there's nothing I can do about it. Actually, genes can be turned on and off by what we do in our environment. So actually, this gives you a lot of potential opportunity to take control of your health. So that's actually, these are good news.
Thank you. So Dr. Shahed, we'll start with you again. Can you walk us through any advancements in the diagnosis process of Parkinson's?
Yeah, so for the longest time, diagnosis of Parkinson's disease was a clinical diagnosis, and I'll actually say that it still continues to be clinical. What that means is somebody could walk into my clinic and have typical symptoms of Parkinson's disease. I may ask them certain questions about how it started, what changed over time, how did it evolve, et cetera. And if we're applying those right kind of criteria to ask the right questions, to do the appropriate examination, we can actually be pretty accurate in the diagnosis. And there's some really kind of old studies, probably 20, 30 years ago, that looked at if we do those things properly and then we look at a patient's brain after death, that we're pretty, like, I don't know, upwards of 95% actually accurate in it. So it really can be a clinical diagnosis. Having said that, we do have more tools at our disposal. So if there are questions about the particular way that a person's symptoms are presenting, or maybe there's some uncertainty about it, or maybe there's just a desire to have a little bit more objective confirmation of symptoms, there has been a scan that has been available now probably for, I don't know, I would say 15 years or so, a DAT scan, which can actually measure the dopamine nerve terminals in the brain. A lot of the motor symptoms are actually related to losing the cells that make that chemical, and we can image those nerve terminals using this DAT scan. So somebody with Parkinson's would have a reduction in the the pictures that we can see that are kind of highlighting those particular nerve terminals. Two other kind of clinical tests have also become recently available. One is a skin biopsy that can show evidence of the protein that accumulates in Parkinson's disease. This is called alpha-synuclein. And although we're primarily interested in how alpha-synuclein acts in the brain, there's actually evidence that it is also present in other parts of the body. And we can do skin biopsies that can demonstrate that. So for some individuals, that may help confirm the diagnosis. And then the last thing that has most recently become available is actually a spinal fluid test. And this one also looks at the different proteins that are in the spinal fluid, and there's particular electrical signatures of chemical signatures of Parkinson's disease. I'm jumping ahead to the DBS conversation. Chemical signatures that are associated with Parkinson's, and so that can also be confirmatory. So we have these extra tools at our disposal.
Thank you. And is there anything else, feedback-wise, you would share with the community if they're maybe going through the diagnosis process, about length of time? Any tips that you can give?
So I think that if you're recognizing symptoms or if you're concerned about symptoms, obviously you need to mention these to your doctor. I think a lot of people start with their primary care doctor, which is great, and that's fantastic, but often that should maybe then be evaluated by a neurologist. So there are a number of general neurologists out there, but those that specialize in Parkinson's disease, like myself, are individuals with expertise in what we call movement disorders. And so you may ask also for a movement disorder specialist to take a look.
Fantastic. So Dr. Kopell, and I know that you're passionate about this, I'd like to ask about exercise and diet. Is there a specific exercise and diet you would recommend?
I am very passionate. Let me start off with a visual aid, if you will. Can I turn on those slides for a moment? Okay, this is a great slide. Okay, so I'm a neurosurgeon, so I do my day job's brain surgery, but this actual patient was the one that got me really interested in exercise and nutrition as an adjunct to treat my patients. And you can see, if you look in his upper chest, you can see the little pacemaker units from the deep brain stimulation device that we implanted. And I'd love to say that the reason why he's running this triathlon here is my vast skill as a surgeon, but I realized more humbly that there is an X factor here in terms of how patients do even after surgery. And I felt that it really did have something to do with the lifestyle that this gentleman chose. And so, one of the things about the diseases of aging, and Parkinson's disease is a disease of aging, is that if you look at it, there are really three fundamental forces that drive all diseases of aging. There's inflammation, chronic inflammation. There's insulin signal processing problems, so essentially insulin resistance. We think of that in terms of type 2 diabetes. And the third is mitochondrial dysfunction. And if you look at almost every disease of aging, cancer, obesity, heart disease, and yes, Parkinson's disease and things like Alzheimer's, they have that as well. And so, do I hit the yellow button? I guess
The black.
The black one? Nope.
Can we get the next slide?
Nope, there it is.
Okay. So, there are two things that I, in my patients that I've seen sort of confusion on. So very often patients come to me sort of with more advanced Parkinson's disease, and by this time they're beginning to sort of avoid protein in their diets because it interferes with the absorption and the efficacy of their medications. And that's a real Faustian bargain. It's like a deal with the devil. Yes, you can kind of hack the drugs to work better, but very often patients become frail. If you lose your muscle mass, it really becomes problematic as we get older, both from cognitive standpoints, balance, all the things that patients with Parkinson's really sort of are worried about, and rightly so. And so one of the things I always tell patients, you've got to make sure that you eat enough protein, which is generally speaking about 1 gram for every pound of lean body mass that you have. Okay, so that's really important to keep up with your protein. But one of the more interesting diets for patients with a neurodegenerative condition is something called the ketogenic diet, which is a higher fat, moderate protein, low carbohydrate diet. And why is this an interesting diet? Well, number one, it addresses at least two of the three sort of horsemen of aging: inflammation and insulin signaling processing problems, insulin resistance. A funny statistic, there was a study from Cedars-Sinai in LA where they looked at 100 patients without a diagnosis of type 2 diabetes. So these are quote unquote normals, and over 60% of them had signs of insulin resistance. This is really part and parcel of Parkinson's disease. This type of diet has been shown in animal models as well as clinical studies to be potentially disease modifying, especially in regards to the non-motor features of Parkinson's, like the cognitive aspects of it. So that's one thing that I talk to patients about it. And as I said, there are a number of studies that have already linked this ketogenic type diet to a better course of the disease. The other thing is exercise. When patients come to me, they very often say, well, I do exercise, I walk. Well, walking is good. It's good to be active. But walking isn't enough to sort of trip that signal of exercise. Exercise has to be a little bit effortful. And one of the most important types of exercise that very often patients come to me sort of not doing is resistance exercise, lifting weights. It is super, super important to engage not just in aerobic exercise, but in also resistance training in order to maintain your muscle mass. The more muscle mass you have, the better insulin sensitivity you will have, but more importantly, the better balance you will have going forward. I'll leave it at that.
Thank you. Dr. Shahed, did you have anything to add?
No, I think this is a really great point. I think oftentimes, as Dr. Kopell was saying, we begin having these conversations with patients once they come in and we're starting to diagnose them with a neurologic condition. So what I think is also maybe worth considering is just sort of having that kind of lifestyle leading into it, because I think that people who come from sort of a place of better health, better performance, kind of a routine and a kind of regular schedule of engaging in these kinds of lifestyle activities, I think their course overall is also better compared to people who don't. So I think just for brain health in general, right? I mean, these are all great things to do.
We actually, Spark Your Health, just did a talk on Alzheimer's disease, and we were talking about the ketogenic diet. Yep. So it's interesting to see how beneficial that can be across the board.
Yeah.
Yep.
So sticking with quality of life, Dr. Shahed, can you recommend to Parkinson's patients any adjunct to medications, things like speech therapy, physical therapy, occupational therapy? Would love to hear a bit more about what's available.
Yeah, so I think alongside like dedicated physical exercise and that kinds of things, a lot of these other ancillary therapies are really important in Parkinson's disease. And I think when somebody is first diagnosed, obviously they may come to us at various stages of symptom severity, and there may not be so obvious of a need of those types of things right away. But over time, as we are treating the condition, there are certainly a lot of symptoms that will get better with medication. But beyond that, we do need some extra of these kinds of things to sort of help people improve their overall well-being, their overall functioning. So I do recommend this very frequently in my patients with Parkinson's disease. So PT, physical therapy, is obviously a great one. There are some dedicated physical therapy programs for patients with Parkinson's. There is something called LSVT Big, which really kind of addresses a lot of the difficulties and challenges that people have on a regular basis. So it's not just like going to the PT and here do your round of exercises, right? I mean, it's really Parkinson's focused. So I really enjoy that one, or recommending that one. Alongside that, there is it's kind of a combination exercise physical therapy thing. It's called Rock Steady Boxing. So what they do is a lot of, to the extent that a person can do, actually. And so you might see in a Rock Steady class a patient, like a wide range of patients in terms of their symptom severity. But it involves that kind of exercise, but there's also a lot of physical therapy that's incorporated into that, and also some cognitive challenges as well. So that's another holistic one. Speech therapy, obviously, this is a condition where voice often tends to get softer. It's harder to project the voice. People may, in sort of social situations, be it might be difficult to communicate, and that may actually lead to a reason for withdrawal. They don't want to be around people because they always have to repeat themselves or somebody's always asking them to do that. So speech therapy, in particular LSVT loud, is also directed specifically at the issues that Parkinson's patients experience. And then occupational therapy is sort of, I think sometimes we joke that it's arms versus legs, but really what occupational therapy is your activities of daily living. And how are you getting around the house? How are you doing things in your regular environments, and what can we do to facilitate those things? So all of those are helpful. There's many more, actually, but those are some of the 3 core ones that we do.
And if anyone is interested in learning more about LSVT Loud, in the Spark Your Health Archives page, we do have a recording that talks all about that. I'll make sure that I put that in the post-event communication that goes out to everyone, so you're welcome to watch that. And we also offer a Parkinson's exercise program here at the 92nd Street Y, developed with Mount Sinai physicians and our associate director of group exercise. It's a wonderful program that includes boxing components as the majority, so I agree with all of that. So we're about to get into the more surgical side of things, but first, can you tell us what advancements there have been in non-surgical treatments for Parkinson's disease? And I'll open this up to both of you.
Yeah, so kind of the mainstay of treatment, so I may not have sort of really highlighted this at the beginning, but a lot of the physical symptoms of Parkinson's that I mentioned are related to having that loss of dopamine cells, right? So dopamine levels are low. Dopamine is a brain chemical that's really important for helping to coordinate our movements, help them to be precise, et cetera. And so when you don't have enough dopamine, you're stiff, you're slow, you're shaky, may have trouble with walking and balance. So most of the therapies that we have for Parkinson's disease center around treatments, medical treatments, I should say, center around something related to dopamine. So you can either replace dopamine, you can stimulate dopamine receptors to kind of make the brain think that there's more dopamine activity going on. You can prevent the breakdown of dopamine. You can also change the way that dopamine is delivered. You can do it either by a pill that you take periodically or often multiple times per day, or there's other continuous delivery methods. But increasingly, we're also finding, and there's a lot of interest in trying to find ways to help the dopamine system work better by targeting other brain chemicals. And there's now 2 or 3 other medications that are currently available that kind of don't directly affect dopamine, but they can improve the way that the dopamine system is signaling and the way that the dopamine system is functioning. So a lot of this research, this is a big area of research in terms of therapeutics and drug companies trying to come up with new treatments for Parkinson's disease to find ways other than just dopamine replacement therapy to treat the condition. So we're fortunate now, I think, in this day and age, to have many medications at our disposal to try to effectively manage the symptoms of Parkinson's disease. But I think, as we'll discuss, there still may be some challenges there.
Yes, thank you. Before we get into surgical options, Dr. Kopell, did you have anything to add to non-surgical?
No,
Okay.
that's well said. Yep.
So then let's dive in. So can you tell us about the surgical treatment options, Dr. Kopell, that are available?
Okay, so currently there are 2, and actually let me start up with a slide because I think putting it in context, if you don't mind putting that on again.
We can get the slides back.
All right, let's see here. Okay, great. So, there are essentially 2 main surgical options that we have available for you if and when the time comes. Probably the gold standard is deep brain stimulation. And deep brain stimulation can be just sort of colloquially thought of as a pacemaker for the brain, much in the same way that, like, when patients develop heart arrhythmias and you put a pacemaker into the heart and you can regulate the arrhythmia and relieve the symptoms thereon. Essentially, all of the symptoms that we see as part of Parkinson's disease, the outward manifestation, the tremor, the dyskinesia, bradykinesia, all of these are the result of abnormal electrical activity in the brain, and in the same way that if you put a pacemaker inside the brain and regulate those signals, you actually treat symptomatically the disease. And then the second one is MR-guided focused ultrasound. People have probably have come across this in their travels around the internet. MR-guided focused ultrasound is essentially a new take on a very, very old technique that predated DBS, which is essentially burning a tiny little hole in critical areas of the brain that regulate these circuits as well. In essence, if you develop one of these three things that you see over here, you're a candidate for a surgical procedure. And what do I mean by that? Essentially is if you develop one or multiple of these sort of entities that you see up here, and I'm sure Dr. Shahed will talk about that in a moment, your quality of life will be much better with a combination of surgery plus medications than just soldiering on with medications alone.
Thank you.
So I can maybe break those down a little bit, actually, if that's helpful. So I talked about the dopamine replacement therapies. The main dopamine replacement one is levodopa, and for decades now that has been the gold standard. Yes, there's a lot of research going on trying to find out if there's some new gold standard that we can find, but essentially taking levodopa replaces what your brain is not making enough of. So this is, that's a high standard to kind of try to either replicate or to supersede. But one of the challenges with levodopa, despite how effective it is that over time people will start experiencing kind of it's not really even, I think generally speaking, people have this perception that it starts losing its effect, and that maybe isn't quite exactly what happens. The medication will always work, but it may take higher doses to get the same effect. And then what will happen is that patients over time will start to feel like the effect of the dose is not lasting as long. That's something that we call a wearing off phenomenon. Another term for that is written up here is motor fluctuations. So the idea that things are kicking in, wearing off, kicking in, wearing off, that is a motor fluctuation. That's an unfortunate sort of consequence of the way that levodopa works and the way that the brain handles the levodopa, which can actually change over time. The other thing that's mentioned here is dyskinesia, the second one up there. So dyskinesia is that abnormal, excessive, kind of twisty, turny body movement, and that can also be more likely to happen as the disease progresses. There are certain patients who might be more prone to developing the dyskinesias, women, especially lower kind of body, BMI sort of situations. Those patients may be more prone to it. Younger patients are more prone to developing dyskinesias. But if you're experiencing the fact that you take a medicine, it works, but then it overshoots and you get the dyskinesia, and then a short while later it starts wearing off, you can imagine how difficult it is to just get through your day, right? Because then you're starting to plan your activities. When are my meds going to work? What can I not do when my meds aren't working? So this becomes increasingly challenging, and as Dr. Kopell was saying, we can certainly continue to try to manage that with different medications and different delivery techniques, but sometimes the best way to really kind of get good control over that is with a surgical treatment. What else do you have? Tremor was the other one.
I thought I had another slide that at least. No, I don't. Okay, I thought I did.
So the other one that he had up there is refractory tremor. So tremor, and I think we'll see this later with our patient example, is difficult to treat in some patients. There's sort of two varieties of Parkinson's, well, maybe three, but there's one that is extremely tremor dominant, and then there's a group of patients with Parkinson's who may not have any tremor at all, and that's fine, it's still Parkinson's disease. And then there's sort of like the people in the middle who have a mix of all of the different symptoms. And when we're dealing with somebody who has like a very tremor dominant condition, this sometimes requires multiple medications to try to control it, and sometimes we're just not able to with medicines, and that's the other situation where something like a surgical treatment would be very effective.
I do want to emphasize, whenever they have sort of head-to-head compared like best medical therapy when people have one of these entities versus the combination therapy of DBS plus medication, and they look at quality of life measures, the difference between the combination therapy is so much larger than just soldiering on. It's really striking. And yeah, it's like, if you have God forbid you have a brain tumor, there's no choice in the matter. You got to take your brain tumor out. As Dr. Shahed pointed out, yeah, we can soldier you on with medications, but I always want to give patients this sort of thought process. What does not having quality of life and missing that window, what does that mean for you? It's like, if you spend 5 years with decreased quality of life, you can't go back in time. You can't get those years of picking up your grandchildren and going to parties and things of that nature. So, to be, one of the most common things that patients have told me is, gee, I probably waited too long.
That's a common one, I think. I agree with you. And then the other, I'll just give you another example. A woman that was experiencing some of these symptoms who I was talking to about deep brain stimulation, in her mind it was like, well, it's not bad enough, it's not bad enough. And then she said, she kind of finally had the realization, well, what am I waiting for, right? So, I want to feel better now. And if this is a way to help me feel better now, then it should be seriously considered. So I echo your statements 100%.
Absolutely. And we know that every patient is a little bit different. Are there any factors to consider that would sway, have you swayed towards surgical or towards non-surgical? Can you just walk us through, maybe a scenario or two where it's different?
Yeah, I think the fundamental issues that are listed up here, the fluctuations, the dyskinesias, tremor that isn't getting completely well controlled, these are motor symptoms, and I think that's often the trigger for thinking about should we be doing a surgical therapy, and in particular deep brain stimulation. Having said that, though, as I mentioned before, there's a number of these non-motor symptoms that are also present, and we need to factor those in as well. Sometimes those non-motor symptoms are also things that fluctuate in the same way that the physical symptoms fluctuate. Sometimes they are superseding and really quite prominent and really, creating a lot of difficulty for individual patients. And so when we're considering these advanced therapies, whether it's advanced medical therapies or whether it's advanced surgical therapies for Parkinson's disease, we really want to make a comprehensive assessment of all of these different features so that we can guide patients appropriately. Somebody who's already got significant cognitive difficulties, who's maybe experiencing hallucinations, this isn't everybody with Parkinson's, but it certainly can happen. If somebody is at a point that they're already experiencing those things, DBS may be a problem, or any kind of surgical therapy may be a problem. So we have to think about those things.
And I'd like to just kind of tie it in a bow to the question that we started with exercise and diet. Again, when patients start to develop these features, that's when they start, decreasing their protein intake. They start stopping engaging in regular exercise because it's so noxious to deal with all these things, which literally robs you of your most disease-modifying thing you can do, which is eating right and exercise. And so if deep brain stimulation is applied earlier, it then puts the power back to you to change the course of your disease. So I think that's also a really important thing to think about as well.
So I'm sure some of us are wondering about that gold standard that you mentioned, the deep brain stimulation. So Dr. Kopell, can you elaborate on that a little bit? How did it come to be?
Sure. So as I said, deep brain stimulation is essentially like a pacemaker for the brain. There's an electrode that's generally placed on both sides of the brain in various particular targets, and then it's attached to a pacemaker unit. So how did we get to a pacemaker for the brain? Well, it used to be an operation called either a thalamotomy or a pallidotomy, which is a fancy word of burning a tiny little hole in your brain. And the way we used to do this is that we would map your brain in an operating room, and right before we would insert the probe to make the tiny little hole that's usually only about 2 to 3 millimeters in size, we would electrically stimulate that particular area to look for benefits and side effects. Because, the old adage, measure twice, cut once. Once you burn a hole in the brain, there is no unburning it. You can't program a hole. You can't take a hole back. And so we would electrically stimulate to simulate what a hole might do. And finally, a gentleman by the name of Alim Benabid in Grenoble, France, said, wait a second, instead of burning the hole, maybe we can leave an electrode in and not really perturb as much brain as burning a hole is, and attaching it to a pacemaker. And this gave us this whole new modality to treat that not only is arguably safer, but gives the neurologists who take care of you after an ability to program the device and sort of modulate your therapy as your disease changes. So that's how that evolution came about.
And we actually just last year came upon the 30th anniversary of the first deep brain stimulator that was placed for somebody with Parkinson's disease. So I think that's another question that comes up. Is this a new therapy? No, it's not a new therapy. It's actually been around for a long time. So what has changed is the way that we do it. We understand a lot more about Parkinson's disease. We understand a lot more about which patients would benefit from it and at what time. And there's also been a number of technological advances in the devices themselves that allow us to better care for our patients and get those better outcomes.
And I'd like to sort of emphasize what they, one of the most important things is the 30 years of experience in terms of picking patients. Very often patients say, hey, doc, if I do this, what's the chance of me getting better? And I would say that if you go through our process and our evaluation process, and I say to patients, as long as I get the electrode in the right place, which I do, you're going to benefit. It's not like a if you are going to benefit, you will benefit. That's like 100%. And that really is a testament to our ability to sort of pick the right patient.
And I'll second that statement. He does a great job of getting the electrodes in the right place. So, but that is important. And I think, we do have all of this experience over time. And we do that specifically of that evaluation process in order to make sure that when we're recommending that therapy to you, we're confident that it's going to do what you need it to do. So, yeah.
Very exciting. So Dr. Shahed, let's talk about the potential side effects that could happen with various treatments for Parkinson's disease.
So I think we've discussed some of them, right? So, and these are not really side effects per se, the fluctuations, the dyskinesias, these are really complications of therapy. The side effects of dopaminergic therapies, the pills that you might take for Parkinson's, are things like nausea, dizziness, sleepiness, sometimes hallucinations depending on the individual patient. There's other medications that don't work on dopamine that may have some other potential side effects as well. So these can also be sometimes in some individuals challenging to manage. When we then talk about deep brain stimulation, did you want me to go ahead and go into that as well?
Yeah,
okay.
Sure.
So deep brain stimulation, as Dr. Kopell was explaining, we pick a particular target for a particular patient after going through our evaluation process. What we end up doing is creating a little field of electrical stimulation, a field of electrical energy in that specified brain region in order to get the effects that we need. So it's a very individualized therapy. There isn't like a dial it to this number and that's going to work for you. It really depends on what an individual patient is experiencing. So that's exactly why it is so important that the surgeon is able to do an excellent job of getting that electrode in, because if it's just a little bit off and it's not in that specific place that we think that we need to be in order to control your symptoms, then you start getting the potential for side effects. And these can be things like speech issues, it can be things like worsening of walking or balance, it could be tightening or pulling sensations, tingling sensations, in some cases, sometimes visual changes. I don't want to scare anybody with this conversation, because the other thing that Dr. Kopell said is that this is electricity that can be turned on and off. So none of these types of side effects is necessarily permanent. We can program around it. Again, that gets at sort of some of the technology advances that we have as well. So those are, hopefully when I'm doing my programming sessions, if I see something like that, I'm going to change course really quick. I'm never going to send you out of the office with any of those issues.
Dr. Kopell, anything to add?
Not necessarily about that, but I
Okay.
guess we'll talk a little more about the surgery.
Exactly. So now we'll go into, if you could elaborate on the workup, the recovery time, into the risk a little bit more, which we've touched upon.
Sure. The workup of the surgery is a village effort by our center, and I encourage you to, if you pick a center for surgery, that it's truly a center type of approach. I'll go into this a little bit later, but if you look at a lot of centers, it's usually just one neurologist and one surgeon working together, which is fine, but our center is a bit more comprehensive. We bring a lot of different folks to the table to evaluate you. You typically undergo what we call an on-off medicating test, where you come in off your meds, which arguably is a drag to have to, get yourself to the office being off your meds. A neurologist like Dr. Shahed will evaluate you with standard scales to look at what your disease looks like in the off-medicated state. We then give you a challenge of medication that gives us an idea of how your disease changes with the medication. That helps us not only decide whether you would benefit from DBS, but what potential targets may be the right target for you. You undergo a cognitive test with our neuropsychologist because, again, Parkinson's disease is not just a movement disorder, it's a thinking and a cognitive disorder, and we do that to treat you completely holistically. And then you undergo a very dedicated brain mapping procedure in the MRI as a roadmap for your surgery. And then after all that is done, we all get together. Dr. Shahed leads this conference, and we talk about you, and we look at your videos, and only after, you don't just, if you come to us, you don't just have one movement disorder neurologist, you end up having like 12. And so we come to a consensus, and then that's kind of how the workup goes.
Yeah, and I'll just add to that our team in particular, we have benefited from the added expertise of psychiatry and psychology. And again, getting back to these non-motor symptoms of Parkinson's disease, the other aspects that we measure, aside from the motor symptoms in that on-off testing, is actually doing a comprehensive psychiatric evaluation, a psychological evaluation, and even a neuropsychological evaluation. So there's actually 4 components to that pre-operative assessment that we do. I think we're pretty unique actually in the city and in the area in terms of being able to do that. We do that partly because we know that patients may have a number of different symptoms. We also know that the process of DBS, it's not like getting your appendix out, right? You have an appendix problem, you get the surgery, you're fine. Here we have a whole process to deep brain stimulation after. Sometimes I say that the process of DBS and getting better with DBS starts after the surgeon has been able to put in the device, because it takes some time to get everything regulated. So we want to know, are there other issues that are going on that we also need to pay attention to? And that's why we have this sort of comprehensive team evaluation.
Dr. Kopell, did you want to get into complications?
Yeah, so look, any surgical procedure comes with complications. And I think it's important to know about these complications going into the surgery. I'll sort of broadly discuss them here just so that people can kind of put it in context. The scariest risk, the ones that obviously patients are most scared about, and rightly so, is bleeding in the brain or stroke, which happens on the order of about 1% of some bleeding in the brain. The likelihood of something severe happening as a result of that hemorrhage is under that 1%, so it's rare. There's about a 3% risk of infection. Infections can be dealt with just with antibiotics. Occasionally it means that we have to take the device out and start again. The device can break. It's about 3% of the time, and that's like any man-made device. It can break, and if it breaks, we have to fix it. And then there's about a 1% risk of having a seizure after the brain surgery component. Generally speaking, these devices are put in a staged fashion where the electrodes go in the brain, and then as an outpatient, the pacemaker unit goes in. And after the brain surgery part, you can have a seizure, and again, it's rare. It's about 1%. So those are kind of the broad complications.
Yeah, and I think this is part of the reason that we want to time the surgery sort of appropriately. Sometimes we'll get patients who are kind of worried about taking the medications, and they're maybe very interested in what surgery can offer them as an advantage over medications. But there are risks, as potential risks, as Dr. Kopell was talking about. So we do it at the right time when we feel like we're really reached that point where meds are giving us trouble.
It sounds like there's been a lot of positives as well, so I'll pose the question to both of you. Can you speak to what patients can expect as far as improvements, reductions in medications, increasing quality of life?
Yeah, so again, the main reasons that we consider and the time at which we consider DBS is when patients are experiencing these 3 things, right? So these 3 things are the target, the main target of the intervention, and these will all get better. So if you think about what I was describing, and I think that's what that picture is up there. You sort of take a dose of medication, you get better, and then it wears off. You have to take another dose of medication, and your symptoms are fluctuating throughout the day. When we apply deep brain stimulation, the expectation should be that we're able to get that steadied out. So the on times get longer, the off times reduce, the dyskinesias should go away, any tremor that was not well treated should be well controlled. These are the primary expectations. And then along with that, as you can imagine, if we're saying all of these things are also negatively affecting your quality of life, it makes sense that once we start regulating that better, quality of life will also improve. And I think that's what time and again the studies have shown.
Dr. Kopell,
Yeah,
anything?
yeah, sort of like people like numbers. Generally what I tell patients, think about the best time of your day where you're well medicated, you don't have any side effects. We're going to keep you there 70% longer. And think about the worst time of your day when the meds haven't kicked in, you're not feeling great. We're going to reduce that by about 70%. I can take 80% of your tremor away, and I can take about 80% of your dyskinesias away. So you're talking about a really, really substantial reduction. And yes, the average patient gets about a 50% reduction in their medication burden, but I generally don't lead with that. But yes, patients really find that appealing as well.
I think that's another important point because people are hopeful that the stimulator will take the place of their medication management. So a lot of times the reason you're taking so many medications is because we're trying to regulate the symptoms, we're trying to keep you on, so once we do that better with surgery, yes, we get to reduce the meds, but there are actually things that medications do that the surgery can't do, and so for although there are some patients who can come completely off, I'll just lay that out there, that's not the majority of patients, and that's certainly not the expectation that we want to give patients because our goal really is to get you functioning better. We want to improve your quality of life. If that takes stimulation and a little bit of medication, I would be happy to kind of achieve that for you, and I think that's really the goal that we are looking for.
Well, I think a wonderful opportunity that we have today is to actually invite a patient up who is a successful story of this DBS that we're talking about. So Eric Rose, can I invite you to come up here? And we will do a little demonstration for everyone.
It's still off.
It's still on. Yeah.
Still on, yeah.
You can tell, right? Okay. All right. I'll go ahead and take this. Thank you. All right. So do you want to ask a couple of questions first, or do you want me to?
Sure. I mean, I'd love to, if you could help describe how DBS has changed your quality of life on a day-to-day basis.
I have a life. Before doing this, actually I tried focused ultrasound because my Parkinson's was originally diagnosed as essential tremor. So it didn't work. Well, it worked for about 3 months. And then the tremor came back, and it was clear that I had Parkinson's, not essential tremor. And I'm familiar with the difference between, I'd say you have a program as opposed to a practice of Parkinson's disease and surgical therapy. And there's a big difference between practices and programs. Practices are great if you're not sick or you want to stay healthy. If you're sick, I ran a heart transplant program at Columbia as a surgeon, but it was clear Dr. Kopell's expertise is better spent, I'm sure, in the operating room. Dr. Shahed and her colleagues, have an expertise, a deep expertise in the disease itself. And what I didn't hear, their experience also spans, this is all they do. And most practices, people are generalists because of the economics of practice or whatever. And I really think when you're sick, there is no better way to get care than by a team. And a team that is used to each other, that can complete each other's sentences, frankly.
Sounds like it was
Yeah.
truly life-changing.
Yeah.
And tell us a little bit about the surgical process.
Well, I've been through a lot of surgery to begin with for other things. And compared to, for example, abdominal surgery for a gallbladder, this is easier. Because one, you can be awake during most of the surgery. The thing that for me was most difficult about the surgical process was not the pain or that stuff. It was the fact that I went through all this and the box wasn't on yet. And that's frustrating as hell. You go through all this and you have this thing even sitting in your body or not yet sitting in your body, or you have the electrodes in your head, which is, there are a couple little bumps that I got used to pretty quickly. But my wife was with me when we turned the box on in Dr. Shahed's office, and it was miraculous.
And about how long do you have to wait to turn that on from the surgical point?
Typically, after the pacemaker unit is placed, we usually start programming just sort of by convention about 2 weeks later. It's no magic number, especially with the current generation of devices, but about 2 weeks, give or take.
I think the bigger concern is that when, and the reason sometimes that we, well, not sometimes, but we always wait, when you put the wires in the brain, you know, it's a foreign body. There's sometimes a little bit of a reaction that can happen, not in a negative way. What actually ends up happening a lot of times is sort of, and I can't remember if you experienced this or not, but just the act of putting the wires in, people may feel better because there's just maybe a little bit of irritation or swelling around the tip. And that may be there. It gives you a little window of insight into what the effects are going to be. But we have to wait to have all of that stuff settled down before we start programming, because that may influence if we're doing it at the wrong time, and we may not get to the best settings. So we wait.
Dr. Rose, do you have anything else to share with the audience before we actually show them what this can do?
No, it's fine.
All right, he's raising him.
We appreciate you doing this, truly.
He's done this before. So what I'm going to do before turning it off, if you don't mind, could you put your arms in your lap? So we're just going to demonstrate a few things with Parkinson's. So can you count to 10? Just out loud, 1 to 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay, and then arms out straight in front of you. Okay, so we're looking here, very little to no tremor, right? Elbows out to the side. Yeah, bring them out this way. Okay. Okay, so pretty steady, right? And then touch my finger here, touch your nose. Okay, good. How about the right hand? Okay, good. All right, perfect. And then just take both hands and tap those thumbs for me. You can do both together. Yep. Okay, and then we're going to do this. These are all exam tasks that we do to see how much Parkinson's symptoms there are. Okay, and then we can go this way as well. So pretty well coordinated, no tremors, right? So the DBS, turn it off. And it may take a little bit, like a few seconds, but generally speaking, once we do this, after whatever the period of time is, then symptoms start to come out. Are you feeling anything?
No.
Not yet. It's like taking your car to the mechanic.
Right.
All right, starting to come a little bit there. Yeah. So while we're talking about that, your symptoms of Parkinson's were very tremor dominant. So this was an example of a patient who we talked about who has a lot of tremor that was not sufficiently managed with medication. So that was ultimately the reason we ended up doing the deep brain stimulation device. The medication that you were taking before really was not helping too much. You actually weren't taking very much medication, but you're fortunately, what are you doing with meds now?
I'm on
Parkinson's,
nothing.
You're on not on. So he's one of the patients who we have not needed to put back on medication.
Yeah, this is...
All right, here we go.
And I would imagine this also helps with the resistance training abilities that we were talking about earlier.
Right, yeah. So, all right, can you describe what's starting to happen?
Yeah, I'm shaking on my right hand, and I'd say it's difficult now for me to communicate because it's so distracting. And I had a pretty active life before all this, most of which I've been able to resume, or at least in part. And socially, it was really paralyzing.
Yeah. Can we do a couple of
Sure.
things? Go ahead and put your arms on your lap, one on each leg. There you go. All right, I'm going to give you a harder task this time. Can
Sure.
you do the months, start with December and do the months backwards?
December, November, October, September, August, July, June, May, April, March, February, January.
So I don't know if all of you guys can see this, but there's tremor in his legs now that wasn't there before. Also some tremor in the hands, which we'll look at here in a minute. Can you hold both arms out straight in front of you now? There you go. So now you can see this tremor coming back, and then elbows out to the side. Right? And then with your right hand again. Yeah, okay. You can start with your left hand.
My other.
All right, and then now the left hand. Okay, so you guys can see, I think some of you at least, that the leg tremor is definitely there. How about with the right hand by itself now? Just do this finger tapping. So would you say that's harder?
Yeah.
Yeah, okay. And then how about the left hand? Also harder to do that now. And then with the right hand, make the fist and open and close it.
See
Okay,
how
also
slower it
harder,
is.
slower to do. Left hand, yeah. And then these twisting movements. Okay, so the deep brain stimulator can treat the Parkinson symptoms, and we talked a lot about the fluctuations and the dyskinesias and those kinds of things, but really it also specifically can help control the tremor, the rigidity, the bradykinesia, all of those main sort of features. I'm not going to ask you to walk because I know that's a little tricky, but that can also, for certain patients, be better as well. Yeah?
Well, thank you. Thank you so much for showing. And for those of you that maybe couldn't see
Turn
in
that
the back, there, Dr. Rose's,
You ready?
light
Sure.
did start going up and down during that, so you can certainly see how those tremors quickly
Oh, yeah.
came back.
Wow.
So it feels different
Yeah.
immediately,
Yeah.
right?
Immediately.
So now you're feeling better, you're calmer,
Yeah.
you're not shaky.
It's just like this wave that goes over you initially.
Yeah. Hold your hands out, just for people. Okay, so back to being regulated, right? So it's,
Is
Very
this
quick.
something that's turned off during sleep,
no,
or you just stays on all the time?
stays on all the time.
Okay.
Right now, that may change, but right now, that is how we usually do it.
Okay, that was very powerful. We do have a few more things to get to, but I do want to just open up if there are any questions about this specifically. Jennifer, do we have a microphone? If you feel comfortable without the microphone, we can go ahead and, start here, and we'll just repeat the question.
My question is, when you did the DBS surgery, it affects the whole body, not just one side?
So the question was, does the DBS surgery impact the entire body and not just one side?
So generally speaking, if you come to us with symptoms on both sides of your body, then we put an electrode on either side of the brain to control the entire body. So the short answer is,
Head and toe though? I mean, if the legs are separate from the arms, or?
Right, so
Yeah.
the right brain controls your left body. So if we're applying stimulation in the right side of your brain, then that's going to help everything on the left side of your body, arms and legs.
We have a microphone now, so Jennifer, make your way around. Looks like there's a lot of questions about this, which is great. Whenever you're comfortable,
Oh,
I'll help you
That's fine.
back over here, unless you
I'm
want
good.
to stay up here.
I'll stay.
Okay, great.
How do you recharge the device?
So the
How
question is recharging the device. So there are different types of batteries. There's one type of battery that doesn't need to be charged, but like any battery, at some point it's going to run out and you will need a battery replacement. And then there are rechargeable batteries as well, which now our technology is good enough that these are lasting 15, maybe upwards of that, years. But you do have to charge it, and the frequency with which you have to charge it may depend on how much juice you're using. Okay? Again, just like your cell phone, the more you use it, the more it's going to drain. Generally speaking, I advise patients to be prepared to charge twice a week, maybe for 30 minutes each time, but in reality, it probably can go longer than that.
How do we get access to charge?
So the question was, how do you actually charge it? So there is a charging apparatus, and I don't know if our Medtronic colleagues, do you have one outside that somebody can look at? But there is a charging device that needs to be charged, and then you just hold it over the battery.
it's like how you charge your phone.
Yeah, but except over you. Yeah.
Wireless, yep,
Yeah.
that's right.
All right, if you raise your hand, Jennifer will be around with the microphone.
I don't think I need it. Are you talking about automated DVS, the new state-of-the-art technology?
We can talk about that. Do you want to do that now or?
So, sure, the question is about automated DBS.
Okay.
Smart DVS?
Yeah, so I think it's called adaptive DBS actually. So adaptive meaning that it adapts to the brain. Okay, so what, and this is a Medtronic innovation, so a technology that's unique to the Medtronic device. As Dr. Kopell was mentioning, during the brain surgery, we actually map the brain. We're actually listening to the brain kind of electrical activity. We can actually now do that with an implanted device. We don't we're not restricted to just doing that in the operating room. So these devices, the wires that are in there that are now in the deep brain structures, they can both deliver the electricity, but they can also record the brain activity. And there's a particular electrophysiologic signal that's associated with a person having more Parkinson's symptoms versus less Parkinson's symptoms. So you can imagine if you're still taking medications and the meds are working, then you might not need as much stimulation because the meds are working. Versus when the meds are wearing off, maybe that's when the stimulator could kick in. So the adaptive DBS sort of takes advantage of this ability to recognize the changes in that signal and then use that to adjust the stimulation within parameters that are set by the physician. So it is kind of a new idea in how stimulation is delivered, because otherwise, as we talked about, it's on 24/7. And this won't necessarily turn it off either, okay, but it will modulate the amount. And the thought is that this will be very personalized, right? So you get the therapy when you need it, but then by the same token, in the long term of deep brain stimulation, perhaps there's some advantages in terms of some of the long-term consequences of stimulation, and also perhaps in battery longevity. So those are some of the key points, I think.
And I think, do we have a battery here that we can show up?
This is the rechargeable.
Yeah, the recharge.
To answer your question, so it's a wireless recharger, just like your phone. And then here's your battery samples you can see out front. But simply you just tap the power button, drape it over your chest while you're watching TV, and it charges up. That's it.
Thank you. All right, Jennifer's coming around.
Hi, thanks. How long is DBS efficacious for?
Indefinitely. So, we have patients that are decades out that are still getting benefit. The sort of corollary to that is, how does your disease change over time? So different patients have different courses of the disease. And so some, unfortunately do become very infirm, and the functional benefit is a little bit harder to tease out, but if you look at the actual absolute benefit within a patient, that benefit remains nearly indefinitely.
And I think there have been, I think the longest study to date in Parkinson's that describes a large group of patients is 20 years. So there still are good improvements in tremor, in the bradykinesia, in the rigidity. So all of those motor features that we talked about can continue to be very well controlled over the life of that individual.
Jennifer, maybe we can get someone from this side of the room. Are there any hands up over here? No? Okay. Here we go. Gentleman in the Mets hat.
Any research being done on increasing or use of insulin or other medications that might increase the efficacy of use of insulin? And secondly, regarding any idiosyncrasies in the physiology of the brain, for instance, abnormal amounts of collagen affect the electrical stimulation.
Okay, let me tease out two of those things. So the two questions were about the effect of insulin. Is this in reference to my, okay, fine. And then the second thing about collagen deposition in the brain. Okay, fine. Let me answer the second question first, since it's a little bit more straightforward. So, one of the reactions of putting a foreign body in the brain is something called gliosis. It's the way the brain scars. So we don't typically get collagen scarring in the brain the way you do in the rest of the body. That's not how the brain scars, if you will. And so the essence over time, there is a very thin envelope of gliosis or glial cells that kind of wrap around the electrode, over the course of years. It's very, very small and fine. It's something that you couldn't necessarily see on a scan potentially. It's something that you would see like on an autopsy kind of thing, and it doesn't really affect stimulation to a large degree, although it's some of the things that the engineers and the developers of the devices do discuss in terms of developing new electrodes and things of that nature. Okay. Insulin. The issue with insulin just has to do with the pathogenesis of Parkinson's disease. If you have type 2 diabetes, you're twice as likely to develop the dementia of Parkinson's disease than you would if you didn't have type 2 diabetes. So I always tell patients it's super, super important, if don't develop type 2 diabetes, which is something that is in our control. And if you do have it, you can take tremendous lifestyle changes to really control your disease. So that's just the sort of the long and the short about insulin and PD as far as that's concerned.
Thank you. We did have some folks that wrote in questions prior to this, so I'll just dabble those in to make sure we get to those as well. Sorry, we'll go right to you right after this. So we had a question come in about medicines that address tremor and stiffness other than Sinemet. This individual is saying they do not tolerate that specific medication. They also mention Ambroxol, having been that's been reported to help with Parkinson's in several studies in England, and they're curious if you have any input on that.
Okay, so the first part was related to medicines other than levodopa that can help with tremor.
Correct.
So probably the main one that we would use if dopaminergic medications are not effective in controlling the tremor is something called trihexyphenidyl. There's another relative of that medication called benztropine. These work on a different brain chemical. They work on acetylcholine. And the acetylcholine system is thought to be very important in the generation of tremor, so that if you block this, then that can help with tremor. Now, the caveat is it doesn't help with anything else. So you can't take that medication for your Parkinson's and expect it to help stiffness or slowness or difficulty with walking and balance. So it's used in that very particular circumstance for that particular symptom. I would say other than that, I mean, there are, the studies suggest that any of the other non-dopaminergic treatments that I mentioned to you, there's a medication called istradefylline or Nurians, for example. This works on a different receptor called the adenosine 2A receptors. Again, not directly dopaminergic, but it helps the dopamine system work better. And so there are chances that those medications can help also with some of these symptoms, though maybe not as directly as the levodopa.
Thank you. And then Ambroxol?
Oh, the Ambroxol question, sorry. Yeah, I don't have any direct experience with that. I mean, I think it's something that we still need to learn more about. But yeah, I don't have any direct experience.
Thank you. I'll go to one written in question, then we'll go back to the audience. So someone who has an UPDRS score of 0, we've touched upon this, but just if there's anything else preventative measure-wise that you recommend for patients that are early in diagnosis with their Parkinson's disease, anything else that you recommend for them to delay more severe Parkinson's?
All right, so UPDRS, if you're not familiar with that, this is the Unified Parkinson's Disease Rating Scale. So this is, when I was asking Dr. Rose to do all these different things, it's all part of our UPDRS testing and our examination where we can rate the severity of symptoms. So I think a UPDRS of 0, I don't know if that means on medication. If it's off medicine, you maybe don't have Parkinson's disease, right. Because that's how we diagnose it. Right. There should be some symptoms. But anyway, the question related to what to...
If they what they can do to help delay the onset.
To delay the onset. Okay, so this is better approached like a question of somebody who potentially is at risk of developing Parkinson's disease. Maybe they know it runs in their family or perhaps have been tested. I'm not sure what the particular situation is. There's a huge interest at this point in kind of this path to prevention. How can we make it so that people aren't getting Parkinson's disease? And I think that is such a loaded question because there are so many different potential influences on why an individual patient might develop Parkinson's. But I think the things that we've been talking about, which is healthy living, doing things for your brain health, all of those things are really, sort of the best. So you want to make sure you're exercising, you want to make sure that you're sleeping right, you want to make sure that you're taking care of your mental health. All of these things are and in your diet, of course, as well. So these are all the ways that we would typically recommend for somebody who is trying to push that off.
And look, it depends on how deep you want to go. So aerobic is important too. I didn't want to denounce aerobic activity, but usually people forget about the resistance and they just think of exercise as, quote, the treadmill. But just walking on the treadmill sort of unguided is, it's better than nothing, but how do you make it even better for yourself? Well, there's something called zone 2 training. What does that mean? Okay, so if you get a heart rate monitor, and there's so many of them now, anything from an Apple Watch, you can buy straps that you can put on your chest, And the zone 2 of your heart rate is about 70 to 80% of your maximum heart rate. And it's an easy way to calculate your maximum heart rate for most people. It's 220 minus your age, basically. And so if you keep your heart rate between 70 and 80% for about an hour, there is ample evidence that it can improve what we call mitochondrial biogenesis and mitophagy. And as I said, one of the big problems with Parkinson's disease is mitochondrial issues, and anything you can do to support your mitochondrial health is good. So what's the best way to do zone 2 training? You take your heart rate up between 70 and 80%, and you do that 3 times a week for about 60 minutes apiece. That's a long time, I know, but it's not like you have to run yourself exhausted. Generally speaking, what is zone 2? You should be able to read a book while doing it. It's a brisk walk. You should be able to have a conversation and just barely be out of breath. So it's not arduous, but it's just enough to kind of signal your body to create better mitochondria.
And that type of exercise has also been demonstrated to increase things like BDNF, which is a nurturing factor that is helpful for cell survival.
Yep.
So in addition to these kind of biochemical effects and on the cellular level, we know that for the neurodegeneration, these are also helpful as well.
Thank you so much for that. I think it's really helpful to get kind of concrete, practical ways that we can support this. So we'll make sure that those kind of details are in the post-event communication as well. All right, we'll bring it back to the audience.
Hi, I have 2 questions. How long is the wait time to get an appointment with the community?
So the first question is, how long is the wait time to see have a DBS?
And the other is, could you describe the ketogenic diet that's great for Parkinson's?
You talk about that.
I'll talk about the wait time. Yeah, I'll take that one. So the reality, is that there's not enough neurologists in the country to take care of the patients who need us, which does push out the wait time. So I think we have, because we're a center for deep brain stimulation, if the question is about deep brain stimulation, that can be arranged in a very relatively short amount of time. So maybe let's say 6 weeks or 8 weeks or something like that. The regular just sort of Parkinson's evaluations, right now we're probably at 3 or 4 months. 3 or 4 months, yeah.
Okay, ketogenic diet. The standard American diet, the one that most of us are eating, where most of, there are three what we call macronutrients. All of our food is made up of 3 things, right? There's protein, fat, and carbohydrates. And most of us are eating our majority of our calories with carbohydrates. It's just more prevalent. This sort of flips it on its head. So instead of most of your caloric intake is carbohydrates, it's now fat. And so it's about a 70% fat, 20 or so percent protein, 10% carbohydrates. And when you do that, you actually start to create a chemical in your body called a ketone body, which is the 4th hidden macronutrient in your body that you generally don't create unless you create the environment to make those things. And what's really interesting about ketone bodies is that they are directly neuroprotective. So that's why it has some very compelling sort of aspects for Parkinson's. And just so, remember the old commercials? I'm not just the president, I'm also a client. Remember the hair club for men? Does everybody remember that? So I've been on a ketogenic diet now for about 15 years. So, I do this in my own life for a variety of reasons because, again, the thing about Parkinson's is that it's as if just a tiny part of your brain just got a lot older than the rest of you. The same forces that drive all of aging is really sort of fundamentally what is driving Parkinson's disease and Alzheimer's and all these other things. But it's just a little tiny area for whatever reason happen to get really older. So if you kind of do these things that are good for aging, it'll be good for your Parkinson's.
What are foods that are rich in fat?
What's that?
What are foods that are rich in
Oh, there's all sorts of things that are rich in fat. Avocados are rich in fat. Meats, animal proteins are rich in fats. Butter, coconut oil, olive oil is monounsaturated fat. Yeah, so in other words, it's to embrace all the things that for for 4 decades, the medical industrial complex told us to avoid if we didn't want to die.
I'm sensing a follow-up
And-
Park Your Health
Good.
talk on this topic.
And this is a hard surgeon, so but right,
All right, we'll take the next question.
right.
Did we get you? Does yoga have any benefits?
Does yoga have any benefits that we know of?
So again, there's a lot of different exercises that people can do, and there's certain ones that are focused in the way that Dr. Kopell was talking about. I think yoga is, if that's something that you enjoy doing, then that is a great thing to continue. I don't know that there's any specific evidence that yoga is better in any specific way compared to other forms of exercise. One of the things that a couple of things that I really like about yoga for a Parkinson's patient is the emphasis on flexibility and the emphasis on balance. So I think it's a great one to do if that's something that you enjoy.
Yep.
I have Parkinsonism, and I was wondering if you thought the deep stimulation surgery would help or not.
Okay, so I think the statement was that you have Parkinsonism, maybe not Parkinson's disease, and what's the role of deep brain stimulation in those conditions?
If it would be beneficial to take the deep brain.
Okay. So Parkinson's disease, as we know it, is really probably Parkinson's diseases, okay?
Yeah.
Because there's lots of different ways biochemically that people can come at having the same symptoms. However, having said that, there is another group of conditions called either atypical Parkinsonism or secondary Parkinsonism that are really conditions where you have features that are similar to what a Parkinson's patient may have, but the underlying biochemistry of it is very different. So whereas Parkinson's disease is, a lot of the symptoms of Parkinson's disease are related to losing the cells that make the chemical called dopamine, in the atypical Parkinsonisms that may not be the case. So the dynamic is extremely different in terms of both how we treat it medically, but then also that has significant relationship to what we might consider doing surgically. And generally speaking, people with atypical Parkinsonisms do not have a response to deep brain stimulation, at least not as the way that we're doing it currently.
So, do I need this?
You don't need to if you don't want to.
It's a long question about the keto diet, somewhat familiar with.
Yeah.
The first question I wonder about is like all of that fat that cause cholesterol issues.
Sure.
The second question is, it's hard enough for the general population who wants to attempt that
Right.
to stick to it. I wonder how with the PD population it would be more of a challenge to do that. And for whatever reason, what happens if you're Parkinson's is an absolute carbaholic? No
Right.
judgment or anything.
Right.
That would be the most onerous thing in the world to try and accomplish, like going super low carb for the rest of a person's life. I'm wondering if there's maybe a happy medium, sort of like a Mediterranean light without so many grains or something like that. Is that a realistic sort of compromise?
So there's a lot to unpack here. So your first question is a complicated one, but let me start off with the latter. Any habit that we start, even from exercise program to changing your diet, is effortful and takes change in your life. So that's it. Anything that you want to do that has benefit just does require effort, and I have put many patients on ketogenic diet long term. I've done it myself. I travel all over the world. It is possible to do. It's just a question of realigning how you think about food in your life, period. And I like to eat, for sure. I do. So number two, with regards, you said to the
Cholesterol.
the cholesterol. Okay, so cholesterol is a very interesting thing. So it is no doubt that plaque in the vasculature of the heart and the brain is made up of cholesterol. Every cell in your body is made of cholesterol. Cholesterol is essentially the building block of your body. So the idea that cholesterol in of itself is toxic is an absurdity on the front of it. And then, and if you look at the data, like over 60% of patients, or somewhere between 50 and 60 of patients, first heart attack in the ER have normal cholesterol by current medical design. Yes, cholesterol is not the smoking gun that it is generally sort of purported to be. It is it is necessary but not sufficient to develop heart disease and cerebral vascular disease. What are some of the things? Oh, inflammation. So if you look at a lot of these studies where they've controlled for inflammation and platelet dysfunction, which is a consequence of insulin signaling and inflammation, all of a sudden the effect size of LDL really gets really low. So your cholesterol in of itself should not be dissuading. In fact, there was just a huge study that was just presented at UCLA where they followed people for 2+ years and compared them to a control group in the ketogenic, where their cholesterol sometimes, there are some patients that are very lean, very metabolically healthy, and when they put them on a ketogenic diet, their LDLs can go as high as 280, 300, which in tradition would cause your internist to have their own heart attack. And what they did was they followed these patients for 2 years looking at calcium scans of the heart, and they had absolutely 0 scores over years of having this. So cholesterol per se, in of itself, is not something that should dissuade from you. Now, you ask, like, can I do it a little bit? For most people that come to me that are interested in optimizing their health, I generally do a ketogenic diet just to get them sort of understanding it, and then I modify it. For patients with Parkinson's, I would argue this. You do have this neurodegenerative condition. The more ketones that you keep in your body, the more likely that they can be neuroprotective. So you're not, you got to kind of decide how you want to sort of attack this disease. So that's kind of how I would put it.
Thank you for that. All right, we have time for probably just about 2 more questions.
Thank you. Accepting that one has Parkinson's, accepting that there is no cure for Parkinson's that we know of today, and accepting the fact that exercise, aerobic or whatever, is beneficial, it slows down the progress of Parkinson's, but it doesn't stop it. If one can't take the levodopa because of negative reaction, etc., then the only thing that one has at the moment is exercise. Is that a valid statement?
So the question is, if dopamine is not working, is exercise truly the only other option for them?
Yeah, I think I do get this question a lot. I do find patients, and I'm not sure if this is the angle from which you're coming, but they would prefer to do things like that for managing their Parkinson's disease than taking the medication. I think there's maybe a point to which that can be helpful in terms of controlling symptoms, but at some point, if you don't have dopamine, you don't have dopamine. The only way you're going to get it is if you take it. And in fact, regulating your dopamine levels properly may allow you to exercise better. So I think there's kind of a tipping point where it has to be both.
Okay, interesting. Jennifer? Maybe somebody from this side. We might have time for 2 more, I know, and then we'll see if we can maybe get some questions answered for the post-event communication.
Can Parkinson's be triggered by drugs such as Zoloft?
Can Parkinson's be treated with drugs such as Zoloft? Yeah? Okay, so Zoloft, or sertraline, is a serotonin reuptake inhibitor. So its main sort of activity in the brain is to increase serotonin. And serotonin, while it can impact Parkinson's symptoms, is not the primary reason that a person might have tremor, stiffness, slowness, difficulties with walking and balance. So I think the answer is no. I wouldn't routinely manage a Parkinson's patient just with sertraline, although if they had anxiety, if they had depression, if they had other non-motor features, that can be a beneficial medication to use, but just not for the primary symptoms of Parkinson's.
Hi, two questions about the exercise and the exercise. Where can I get information about resistance training, like what exactly to do in terms of resistance training? And also in terms of the exercise, I think you said 60 minutes 3 times a week. If you do like 30 minutes a day, is that equivalent, or is it better to have the longer burst of activity?
So the 60 minutes 3 times a week, generally speaking, you need to be at least 45 minutes in the zone 2 for it to sort of, the signal to start to begin. So six sessions of 30 minutes is probably not as good as 3 sessions of 60. So there has to be a certain time period of that. Resistance training, is a tricky thing. The best thing to do is to hire a trainer who knows what to do, because one of the most important things about engaging in resistance training as an aging human, and I'm about to turn 54, I consider myself an aging human, is to not hurt yourself in the gym.
Yeah.
And so, having somebody who has experience and a good eye aside you as you learn how to train is, I think, really important.
So I'll just maybe add to that a little bit. So in my role as chair of the Science Advisory Board of the Davis-Finney Foundation, this was some of the research that we funded, is looking at specific ways of doing resistance training in patients with Parkinson's disease. So the Davis-Finney Foundation may be a website that you could go to for further information.
And I would say, I'm sure there's a plethora of places within New York City that have training, but here at the 92nd Street Y, we do have the Parkinson's exercise program, and Kareem Collins is very passionate about working with individuals with Parkinson's specifically.
Can I also say this? Obviously there's a gamut of where you are in your Parkinson's. And yes, if you're starting your exercise for the first time where you're a little more advanced in the disease, these programs are great. If you're early in the disease, I say to patients, yes, you have Parkinson's, but you're a human being. Exercise as a quote normal. If you are able to do it, don't just default into, because I've got Parkinson's, I've got to modify this. Many people with Parkinson's can exercise like their normal cohort compatriots. So I want to put that into people's heads as well.
All right, we'll take one last question, and I'm definitely sensing a
she's
oh.
like really.
Right.
I can't sleep tonight unless I find out what she's going to talk.
As long as you're okay.
Hi. Back to the diet issue.
Okay.
Are there connections between alcohol and Parkinson's, either progression or possible environmental impact?
Okay.
The
we could probably both
Right.
answer this question.
Yeah, you answer that, and then I'll give
All
you
right.
my.
So, people always ask, right? So I think there's a couple of facets to the alcohol question. First of all, does it interact with the medications? No, it does not. Unless you are a patient who gets very sleepy after you take your medications, then you add the alcohol on that. That's probably not a good combination. I think the way that I try to sort of adjudicate this issue with my patients, yes, I want you to enjoy yourself and have a glass of wine every now and then, or whatever it is that you enjoy, and everything in moderation is probably okay. But keep in mind that this is a brain condition in which balance is a problem. So alcohol itself, I really advise my patients to try to be very just sort of judicious with how they're engaging with that.
I understand wine and et cetera, alcohol, people like, I get it. But more and more data is coming out that the amount of alcohol that is good for you is zero. The idea that some data that increases HDL, again, that sort of goes to the idea that cholesterol is the arbiter of all your health, and it's not. The amount of alcohol that is good for you is zero. Sorry, I stink, but whatever.
And we are in sober October, so.
Right.
Right here.
Well, my question is coming off Dr. Shahed.
Okay.
When do you start it? Do you have to the dopamine? Is it better to do it while you still have all your stuff together, or do you wait until you fall apart or fall down or your legs stop moving?
Oh, goodness. All right.
The question is about when to start dopamine.
So I think that it's important to remember that levodopa treats Parkinson's symptoms. Okay, so, and that's what it does. It doesn't slow the progression. It doesn't, change the outcome of the disease or anything like that. It is there to treat symptoms. So first and foremost, if you don't have symptoms that require levodopa treatment, then you don't have to take levodopa. Okay, so I agree with that, and I get that. And I think that there are a lot of patients who do have this fear of taking levodopa because, again, as I said, they're worried that it's not going to work. Probably not the reality. It will always work, but it will be harder for it to kind of do what it needs to do. But I think that decision is highly individual, and I personally try to work with my patients in terms of their preferences and their understanding. However, if I see that symptoms are really causing some problems, or I see that it is putting patients at a risk, I'm going to insist that patients at least try. And the thing about it is you can always try the medication, see how you do with it, and if for some reason you don't like that, then you can stop it, but at least make that decision based on what you've experienced trying the medication. So it's fluid, okay? There isn't like a hard and fast. The only other thing that I will say about this is that and there have now been studies that have looked at different medicines that were started at the initial either diagnosis or the initial need for some kind of treatment. They've compared levodopa to dopamine agonist to another type of medication called a monoamine oxidase inhibitor. And consistently in these studies, the patients who are treated earlier with levodopa experience a better quality of life.
So with that, we are going to get ready to close out the program. For those of you that we did not get to your questions, feel free to email them to us at Spark Your Health, our email, and I'll make sure that everyone has that. We'll try to get those answers for you with an email communication. I really, truly want to thank Dr. Shahed and Dr. Kopell for your time. If you have any closing remarks for the audience, you're welcome. The floor is yours. And how to find you.
I'll just say I believe that, if you guys want information about our clinic or would like to be seen in our clinic, I believe we have information out on the table up front. So is that correct? Yeah,
absolutely. If you would like more information on neurology and neurosurgery treatments, please speak to, we have Ian, Ryan, Garrett, Abby, and Evan back there in the Hall of Mirrors. They would be very happy to talk with you further about that. Again, I'm Katira with Spark Your Health here at the 92nd Street Y. We're very grateful to our sponsors of the Spark Your Health program, the Mount Sinai Health System. Clearly, you can see from this conversation, it is a really wonderful team. And again, Dr. Shahed and Dr. Kopell and Dr. Rose here, we really appreciate everyone's time this morning. I hope that everyone learned a lot. And stay well, everyone. Thank you.